A very good evening from Singapore. My name is Tjun, and I would like to thank the organizing committee from the Society for giving me this opportunity to give a talk on the use of ClariVein mechanical chemical ablation for varicose vein management. And what I'll do is also include some technical tips and know-hows using the device. These are my disclosures relevant to this talk. So as an introduction, ClariVein mechanism of action basically uses a dual process, basically using a rotating tip that goes around at 3,500 revolutions per minute to agitate the intima and basically revealing epithelial receptors on board. At the same time, you're injecting a sclerosant drug from the tip of the device that is preferentially taken up by the epithelial receptors to ensure the maximal effect. At the biochemical level, the drug basically fits into these epithelial receptors and basically gets into the media. Then the vein is occluded through this mechanism. What happens is that you get medial disruption, and then you get underlying fibrosis with apoptosis on the adventitial side of the vein. And there have been histological studies earlier showing this observation. So the ClariVein device uses a disposable catheter as well as a motorized handheld unit. And what you do is that you basically create a vortex using the device and attach a syringe full of the sclerosant. And normally what we use here in Singapore is we use FibroVein, and everything is done under ultrasound guidance. The cannulation of the targeted vein is basically using ultrasound, and this is typically done at where the lowest end of the reflux is. The device is inserted without the motorized unit up to the saphenofemoral junction if it's a great saphenous vein, or the saphenopopliteal junction if it is a small saphenous vein reflux. Then you connect the motorized handheld unit to the catheter. And what happens is that you confirm using ultrasound the position of the catheter tip, and you basically pull back in a slow manner and inject simultaneously. And this is the learning curve that you have to develop using this device. And you can see the catheter tip on ultrasound very easily as you agitate it within the vein. And all you're left with at the end is a micropuncture 4 French hole. And this is what what you see on the ultrasound. You see a sclerothrombus within the vein, and this will likely very much block off very soon after. And then you'll do your concomitant phlebectomies after doing the procedure. What we used to do was that we used to use compression bandaging to get good apposition of the vein against the sclerosant. But as I'll show you, I don't think this is absolutely necessary anymore. And this is my post-procedural care protocol at Singapore General Hospital doing this device, or used to be. I used to give them a dose of Clexane to avoid DVT prophylaxis, to prevent any DVTs, compression bandaging for 48 hours, ask them to walk to minimize deep venous stasis. I tend to ask them to wear a class 2 compression stocking for 5 days, which they may remove at night, resume normal activities as soon as possible, no strenuous exercise for 1 week, and then I normally bring them back at 2 weeks to confirm closure of the truncal vein using an ultrasound. And this is some of the results that you can get, and this is a pre-treatment CEP2 patient, and at 3 months you can see the veins have disappeared very nicely, and the truncal vein was subsequently blocked as confirmed on an ultrasound. This is the kind of CVI spectrum that we get in Singapore, very advanced skin changes, and this may be more amenable for using endovenous or less invasive devices for blocking off the truncal vein. So we underwent a dual study with some colleagues from the US, and we looked at Caucasian versus Asian veins in comparison. And what we showed was that Asian patients usually present with higher CEP scores. They have more total great saphenous vein incompetence along with concomitant small saphenous vein incompetence than Caucasians. The diameters in Asians were smaller than their Caucasian counterparts at all levels. And this may be more amenable for using devices which are less invasive, such as ClariVein. Below the knee work is very amenable for using this device as well, as there is no potential thermal injury to either the sural or the saphenous nerves, and very good for ulcer treatment. Also, for the use of small saphenous vein, ClariVein is very useful to go through this field, as you do not damage the nearby nerve. And for very short segments, it's much better than using any kind of thermal ablation. So these are the potential benefits of ClariVein. No risk of thermal ablation. I don't think there's any risk of any skin burns. Generally no risk of nerve damage or paresthesia. You don't need to use tumescent anesthetic, making the procedure much quicker. No multiple needle stick injuries, and potentially setting this up for a much more local procedure-based or office-based work. There's no pain, there's minimal discomfort, and there's minimal bruising. Patients do not need to come for multiple visits, as you can deal with multiple truncal veins at the same sitting. And I think there's generally much more reduced risk. And there is generally what we find a very quick return to normal activities, and it's generally conceived as safe and effective. So we had a look at our 1-year results using the ClariVein device from a single center in Singapore. And what we showed was that the early results, at least at 1 year, are very much in keeping with what has been described so far, although the recurrences in terms of anatomical recurrences are more in the great saphenous vein than expected. Although disappointing, most of these patients who came back were asymptomatic and required no re-intervention. I can just show you some of the data. We collected 120 patients, 141 legs with 180 procedures between 2013 to 2015. About a third of them had concomitant GSV and SSSV reflux, and you can see about a third had quite advanced reflux disease. And you can see the occlusion rates were excellent up to 3 months. And by the time of 6 months and 1 year, you can see that there were early recurrences of the great saphenous vein. There were no technical failures, so you can actually get the device up where you need to. Recurrences were mainly from the great saphenous vein, as I said, and typically this happened around the knee area. The majority required, as I said, no re-intervention. So in true fact, the anatomical recurrence does not equate to clinical recurrence. Clinical recurrence probably is progression of the disease process and basically more varicosities developing. We did a high combined use with avulsion. So this is real life registry work. Minor complications, look at the transient phlebitis rate of only 7%, which is quite low. And you can see the pain scores, the mean pain scores are very low, and patient satisfaction rate is very high. And you do get an excellent cosmetic result with this device. And you can see the distribution of these ClariVein patients. A lot of them had concomitant disease that were treated, so multiple truncal veins. And you can see that there is an early recurrence rate, a higher recurrence rate than with Caucasians at around 6 and 12 months. The only randomized control data to date really is the data from Alan Davis's group looking at radiofrequency ablation versus ClariVein. And this is from the Benefit trial. And what they showed was that the pain was less with MOCA compared to RFA, but with similar short-term technical quality of life and safety outcomes. We did a review article, a systemic review article, a few years back using this device. And what we showed was that you do get excellent, almost 100% technical success rate. You get an anatomical success rate of approximately 90% at 1 year in both the small and great saphenous vein. And this is comparable to RFA and much better than just foam sclerotherapy. And if you look at clinical success rate, again, very good, very meaningful results at follow-up. And to continue on, you look at the thrombophlebitis rates, they're low if you compare it to some of the other devices currently on the market. Basically, patients return to abnormal activity and work very quickly, and much quicker improvement in quality of life. And the intra-procedural pain scores are low with this device. This was a meta-analysis looking at both glue versus MOCA, and what it showed was that they are very comparable, again, at both 6 and 12 months. The problem with glue is that you get this kind of Venezial red reaction and this phlebitic response, much more I've noticed pronounced in Asians and females compared to our Caucasian counterparts, and they can happen anytime, from immediately after the operation to can happen 6, 12 months after the procedure. And we don't really understand why, and this is probably some sort of type 4 hypersensitivity reaction. And even then, you also can tend to get some of these extreme cases where you get by glue rejection and infection, where you sometimes have to remove the whole tract of cast of glue from the subcutaneous tissue. We've been involved with a study with Alan Davis's group, looking at the randomized trial currently almost is finished now, and it's about to report fully, looking at glue versus ClariVein. And we submitted a small sample of Asian patients to this multi-center trial, and you can see the pain scores between the two devices are excellent. They come down very quickly over 10 days, and they are generally actually very low. And you can see the use of compression stockings, no much difference between the two groups. And you can see the improvements in VCSS scores between the two are very similar as well. In terms of disease-specific quality of life questionnaires, not much difference between the ABVQ and the CIVIC-14 scores between the two groups. So actually, in all fairness, you get comparable results using these two non-thermal devices. In terms of long-term follow-up, this is one of the few 5-year outcomes using the ClariVein device, and this is from Reichmann's group, Holland, and he followed up at 94 patients, and freedom from anatomical failure was about 80% at 5 years. There's only 5 re-interventions, and basically VCCS only increased in about 1/5 of their patients. So not bad results at the long-term mark. So in terms of technical considerations, when you use the device, people have issues actually passing this catheter up, sometimes getting stuck within the vein, especially if it's small and with competent valves. I think it's important as you spin this up the vein to visualize the catheter tip. Sometimes you get problems with malfunctioning of the catheter and the motor, so catching of the vein on the vein wall and of any valves, which can cause pain, especially if it's done under local anesthetic. Blocking of the catheter, if you're doing bilateral procedures, can happen. The speed of the pullback is very important in this procedure, and the slower you are, especially in the bigger veins, the better the outcomes in terms of efficacy and blockage. And this is much slower than you would do with an RFA or a laser procedure. Also, I tend not to use these patients, do patients with anticoagulation with this device, because I think the recurrence rates are generally much higher. So in conclusion, I think ClariVein in general, the closure rates are similar for unilateral and bilateral procedures from our data. It is effective, it is safe, and can be performed well in combination with avulsions. You get good functional and cosmetic results with high patient satisfaction rates. So this is my kind of list of tips and tricks for using this device, especially for those people who are just beginning to use this device for ablating varicose veins. I think you should choose an appropriate truncal size vein. I think anything less than 8 millimeters is very amenable for use of MOCA. I think anything bigger than 10, 12 millimeters, I think you are bordering the fact of early recurrences if you're not slow enough and haven't got the technique correct. I don't think you should do more than 2 truncal veins because of the amount of fibrovein or sclerosant that you can use. I tend to use 2% or 3% fibrovein for the great saphenous vein. I tend to use 2% for the small saphenous vein. I do not connect the handle, as I said right at the beginning, to the catheter initially. I think you get a lot more purchase by spinning up the catheter by itself and then attaching the two together. I use a 5 ml syringe with saline to get up the vein, so you can try and inflate the vein as you push the catheter up. Pull back slowly on high speed and never stop. Don't use any other speed settings because I don't think it's as efficacious, and do not use foam within the ClariVein device. And you must inject continuously. I don't think you need to use a pump to do this, because sometimes in the bigger sections, you may need to inject more as you move back. And it's a continuous movement, and it's a simultaneous movement when you pull back the catheter. Obviously, you be mindful when there's a varix or side branches, and you can inject more sclerosant into these areas and pull back even slower. As I said, there's been higher recurrences around the knee, and therefore I do think you need to spend more time with the catheter around this area and potentially give more sclerosant. I tend to use a bidirectional approach if there is a venous ulcer, a CEIP6 leg, and I tend to point one up the GSV around just below the knee level, and then point one right down into the ulcer base and where the venous plexuses are. And for ulcers, I tend to use compression for at least 24 hours. For not only for pain control and for swelling, but I do think you get a better result. In terms of whether you need compression therapy following ClariVein for all procedures, I think this is very much still out for debate. Remember, the process of blocking the vein is actually on the adventitial side, so you don't really need compression of the fibrovein or sclerosant against the vein wall, because it should have been taken up already when you damaged the intima. We're currently running a trial with a group from Ireland to see if compression is necessary. Our early results suggest you do not need to do it in routine cases like CEIP2 or CEIP3. I think the pain scores are very similar, and your efficacy results are very similar at 3 and 6 months. So yes or no, I think you probably don't in the more straightforward cases, but patients, obviously for ulcers, you do need compression post-procedure and to get the ulcer healed. So these are my venous rules to live by when you decide when and what to use. I think you should treat to the lowest point of incompetence, use whatever is safest. Cost is a consideration, and MOCA is generally less expensive than glue for a non-thermal device. I tailor the technique and technology to the clinical setting. Sometimes I use both a thermal and a non-thermal device, although it does push up the cost tremendously. But I do think you need one thermal ablation device as well as a non-NT device in your armamentarium. And in that, I will stop and I will take any questions during the live discussion, and I'll hand you back to the floor and to the chairman. Thank you very much for listening and giving me this invite to speak at your wonderful conference. I hope I can see quite a few of you in person soon.